Assalamu alaikum. My name is Dr. Maliha Siddiqui and I'm a postgraduate trainee in Ops and Gynae department. I'll start with the case presentation. Today the topic which I have chosen is of twin pregnancy. I'll start with the presentation. By the end of the CLB, we'll learn about the etiological factors. We'll discuss management plan of the twin pregnancy along with the complications. I'll start with the history case, that is case presentation. 35 years old patient Guldasta, wife of Ali. She's a housewife, resident of Afghan camp, married since 15 years. She is Gravida 6 para 3 plus 2. She is not sure of her last menstrual period. She came through an emergency with a complaint of 36 weeks twin pregnancy with labor pains for 6 hours. History of presenting complaint. According to my patient, she was in her usual state of health when she missed her periods and confirmed her pregnancy by test urine for pregnancy test done at the nearby clinic. It was a spontaneous conception. First trimester, she had not taken folic acid supplements, no viability or dating scan was done. There was history of excessive vomiting for which she went to the nearby clinic where antiemetics were given. There is no history of urinary symptoms. There is no history of any fever with or without rash. There is no history of abdominal pain or bleeding per vaginally. At second trimester, quickening started at 5th month of her pregnancy. She had not taken an iron and calcium supplement. Anomaly scan was not done. At third trimester, she had a single visit at Fatima Hospital where ultrasound was done at 32 weeks, which revealed that she is having a twin pregnancy. She came with a complaint of 36-week pregnancy with labor pains for 6 hours and was admitted for further management. Previous obstetrical history, she is Gravida 6 para 3 plus 2, had her all SVDs, history of 2 miscarriages at 2 months. Last delivery was 2 years back. There is no history of intrapartum or postpartum complications. No history of pregnancy-induced hypertension, gestational diabetes mellitus, or APH during previous pregnancy. All 3 babies were breastfed and well vaccinated. Gynecological history. She is not sure of her last menstrual period. Age of menarche is 13 years. Duration of cycle was 4 into 28. Flow is moderate. There is no history of dysmenorrhea, dyspareunia. There is no history of instant menstrual bleeding or postcoital bleeding. There is no history of any vaginal discharge. There is no history of contraception. Pap smear have never been done. Past medical and surgical history is not significant. Personal history. Her sleep habit is normal, bowel habit is normal, her appetite, micturition are not or no, all normal. There is no history of any addiction. There is no history of blood transfusion in the past. Family history. There is no history of hypertension, diabetes, asthma, tuberculosis in the family. Her sister is having a history of twin pregnancy. So there is a family history of twin pregnancy. Socioeconomic history. She lives in a rented house, consists of 2 rooms. There is a proper supply of water and electricity, sanitary facility available. On examination, general appearance, a young patient lying irritable on bed, well oriented with time, place, and person. There is anemia was negative, jaundice, cyanosis, clubbing, colonychia are all negative. Lymph nodes are not palpable. Thyroid not enlarged. CNS intact, GCS 15 by 15. Chest normal vesicular breathing with no added sounds. S1, S2 audible. On vitals, pulse was 82 beats per minute. Blood pressure was 110 by 80 mmHg. Temperature afebrile. Respiratory rate is 18 breaths per minute. CNS was intact, chest normal, vesicular breathing with no added sounds. On per abdominal examination on inspection, umbilicus centrally placed, everted linea nigra seen in the midline, stria gravitarium seen. Symphysiofundal height was 44 centimeter, multiple fetal parts palpable leading twin cephalic. First twin was lie was longitudinal, second was longitudinal, presenting part both were cephalic. Liquor was increased. Fetal heart sounds were audible. Uterine contraction in 10 minutes are 3 of 45 seconds, 1 of 35 and 1 of 35. On pervaginal examination, os was 6 centimeter dilated. Length of the cervix was 1 centimeter. Position of the cervix was anterior. Consistency was soft. Station was -1. Bishop score was 9. These were the blood tests which were done in the hospital. Hemoglobin was 10.7. Her platelet count was 145 and the WBC count was 10.1. Blood group was AB positive. Urine DR was normal. Pus cells was 6 to 8. Hepatitis B and C was negative. There was an ultrasound. This was showing that the amount of liquor was excess. Twin alive fetus correspond to gestational age of 32 weeks. It was done at 32 weeks of her pregnancy. The patient got delivered in our hospital, and the first leading twin was female, baby of weight 2.5 kg with the Apgar 8 by 1 and 9 by 5, and the second was also female, baby of weight after 5 minutes. Second baby arrived and with weight was 2.8, Apgar was 7 by 1 and 9 by 5. That was diamniotic dichorionic. I'll start with my topic, that is twin pregnancy. When more than one fetus simultaneously develop in the uterus, this is called as twin pregnancy. There are of two types, that is dizygotic twins, non-identical, and monozygotic twins, that is identical. The definition of dizygotic non-identical twin is the commonest two-third result from the fertilization of two ova. Monozygotic twins are identical twins, that is one-third results from fertilization of a single ova. Dichorionic diamniotic, if divisions takes place within 72 hours after fertilization, the resulting embryo will have two separate placentichorion and embryon. Here you can see in the picture there is a morula. That cleavage at the day 1 and 2 will result in dichorionic diamniotic. And then in the next below you can see that a blastocyst cleavage at the day 4 and 8 and will makes monochorionic and diamniotic. Implanted blastocysts at 8 to 13 will make monochorionic monoamniotic. Formed embryonic disc cleavage at 13 to 15 day will make conjoined twins. This is the best diagram that can describe after the cleavage at certain days will form, these type of divisions will take place. Diamniotic monochorionic, if division takes place between 4 to 8 days after formation of the inner cell mass, when chorion has already developed. Here you can see that there is two amnion and two chorion. That is always dichorionic diamniotic. Monochorionic monoamniotic, if the division takes place after 8 days of fertilization when embryonic cavity has already formed. Conjoined twins or Semsi twins, on extreme case division after 2 weeks of development of an embryonic disc result in the formation of a conjoined twins. There are mainly 4 types of fusion may takes place, that is that the thoracopagus, that is the commonest one, Pyopagus posterior fusion, Craniopagus cephalic position, and Aciopagus caudal fusion. These are the main pictures in which the commonest is the thoracopagus. Incidence, it may runs in the family, may mother may be or the sisters may have the family history, as in this case history you have seen that the her sister was having the twin pregnancy in the past. So there may be a history of family in the past. Maternal age and parity, twin peak at 35 years, 2% after fourth pregnancy. Infertility therapy, assisted reproductive technology. Recent administration of either clomiphene citrate, gonadotropin, or pregnancy accomplished by ART are much stronger association. That is, artificial reproductive technologies are much shorter association. Clinical examination with accurate measurements of the fundal height. Anemia, iron deficiency because of increased fetal requirement. There may be the evidence of preeclampsia. Clinical examination, uterus will be larger than the expected uh, date of gestation. More than two fetal poles can be seen. Two fetal heartbeats at different rates can be present at the time of examination. An investigation ultrasound screening in twin for anomalies, measurement of the fetal knuckle translucency thickness in each fetus by an ultrasound at 14 weeks. Management, how we'll manage early diagnosis and antenatal visits is must. There should be an ample amount of diet. There should be a guidance about the proper diet, how the twin pregnancy female should take proper iron supplements and proper folic acid supplements, and proper diet should be encouraged. Educate the patient about the signs and symptoms of preterm labor. Follow fetal growth by serial ultrasound. Watch and treat PIH and eclampsia. Watch and manage common complications, that is polyhydramnios, twin transfusion syndrome, or intrauterine deaths. Labor and delivery, we can see that during labor and delivery there are many complications which a doctor has to face regarding the patient. A patient may undergo uterine dysfunctioning, PIH, that is pregnancy induced hypertension, fetal malpresentation, prolapse of the umbilical cord, abruptio placenta, fetal distress, and PPH, postpartum hemorrhage, can one of the leading complication in twin pregnancy. These are the commonest position of the twins. 45% is the vertex. Vertex breach is 37. Breach is 10%. Vertex and transverse 5%. Breach and transverse is 2%, and transverse is 0.5%. The mode of delivery, first twin is vertex, will allow vaginal delivery. Caesarean perform if prolonged delayed first stage not responding to the trial of oxytocin when both twins are breech or the leading twin is breech. Usually both twins are delivered before the placenta, but rarely with dizygotic twin the placenta of first twin will come before the delivery of the second fetus. There is increased incidence of PPH, that is postpartum hemorrhage, because of large size of the placental site. There can be a locked jaw at the time of the delivery when the first twin is breech and second is vertex. After coming, the head of the first twin is caught above the chin of the second. If de-engagement not quickly achieved, first twin will die. Then in this picture you can see conjoined twin. Twin to twin transfusion syndrome, monochorionic twin pregnancies, there are placental vascular anastomosis present which allow communication of two fetoplacental circulation. In some monochorionic twin pregnancy, imbalance in net flow of blood across the placental vascular arteriovenous communication from one fetus the donor to the other fetus recipient result in twin to twin transfusion syndrome. In this scenario, the serial ultrasound and Doppler scan should be done to see the flow study in the placental bed. A minor reduction to remove excess amniotic fluid because of rapid decompression may increase abruption. Polyhydramnios in recipient twins may cause preterm labor due to distended uterus. Fetoscopic laser coagulation of communication placental vessels between 16 and 26 weeks gestation is a promising new technique to treat twin to twin transfusion syndrome. Serial amnoreduction and the laser photocoagulation of placental vascular anastomosis. This is the beautiful picture showing both the procedures. External cephalic version. If second twin is non-vertex, which occur about 40% of the twins, vaginal delivery can be preferred. External cephalic version means changing the fetal presentation by manual presentation pressure through the woman's abdomen before performed at 36 to 37 weeks. The complications may include placental separation, cord entanglement, premature rupture of the membrane, precipitation of the premature labor, amniotic fluid embolism, fetal compromise or demise. Contraindications are placenta previa and placenta abruption. Internal pudendalic version, a hand is placed through the cervix, which may be fully dilated into the uterus to turn the fetus. One or both legs are brought down. Commonest indication is for the correction of transverse lie of second twins when ECV fails. Twin reversal arterial perfusion trap. Twin reverse arterial perfusion trap sequence is a rare condition of monochorionic twin pregnancy. It arises when the cardiac symptoms of one twin does the work of supply blood for the both twins. The twin supplying the blood is known as the pump twin. High output cardiac failure leading to the hydrophytalis or polyhydramnios induced preterm delivery. This is a beautiful picture showing the placenta. There is one is acardiac encephalic twin and the other one is twin pump twin. Complication of the twin pregnancy can be divided into maternal and fetal. Maternal includes anemia, preeclampsia, abruptio, placenta, placenta previa, polyhydramnios, preterm labor, APH, malpresentation. Fetal complications include miscarriage, prematurity, growth problems, intrauterine growth retardation, intrauterine death, asphyxia, stillbirth, fetal anomalies, spina bifida, and encephaly chromosomal defects. Thank you very much for watching my video. Hope you will like and subscribe. Thank you.